multiple sclerosis, a disease where the body's own immune system turns against the nervous system, silently destroying the very wiring that makes movement, sensation, vision, and thought possible. In this video, we will explore exactly what happens inside the nervous system, what the patient experiences, and how we manage this complex, lifelong condition. To understand multiple sclerosis, we must first understand the neuron. Every nerve cell has a long projection called the axon, which carries electrical signals from one part of the body to another. Wrapping around this axon is the myelin sheath, a fatty, insulating layer produced by specialized cells called oligodendrocytes in the central nervous system. Think of myelin as the plastic insulation around an electrical wire. It does two critical things. It speeds up nerve signal transmission, and it protects the axon from damage. In a healthy myelinated nerve, electrical signals do not travel continuously along the entire axon. Instead, they jump rapidly from one gap in the myelin, called a node of Ranvier, to the next. This process, called saltatory conduction, allows nerve signals to travel at speeds of up to 70 meters per second. It is fast, efficient, and precise. In multiple sclerosis, the immune system makes a catastrophic error. Autoreactive T lymphocytes, white blood cells that normally fight infection, mistakenly identify myelin as a foreign invader. They cross the blood-brain barrier and launch a full inflammatory attack on the myelin sheath. This process is called demyelination. As myelin is destroyed, the axon becomes exposed and vulnerable. The damaged areas are replaced by hardened scar tissue called sclerosis. Multiple areas of scarring across multiple nerves throughout the brain and spinal cord give this disease its name, multiple sclerosis. These scars permanently disrupt the nerve's ability to transmit signals, causing signals to slow down, distort, or stop entirely. The most common symptom of multiple sclerosis is profound fatigue, experienced by over 90% of patients. This is not ordinary tiredness. It is a deep, overwhelming exhaustion that is completely disproportionate to any physical activity. It is caused by the enormous energy the damaged nervous system expends trying to transmit signals through scarred, demyelinated pathways. Even simple tasks become exhausting. Sensory disturbances are another hallmark of MS. Patients describe numbness, tingling, and a pins and needles sensation, most commonly in the face, arms, and legs. These arise because the sensory pathways in the spinal cord, the dorsal columns, are demyelinated and cannot transmit sensory information accurately. A characteristic sign is Lermit's phenomenon, a sudden electric shock sensation shooting down the spine when the patient flexes their neck forward. Vision problems are often the very first sign of MS that brings a patient to the doctor. The optic nerve, which carries visual information from the eye to the brain, is a common site of demyelination. This causes optic neuritis, blurred or lost vision, loss of color perception, and pain with eye movement. In some patients, vision is lost entirely in one eye during an acute attack. Vision typically recovers partially, but the optic nerve remains permanently damaged. Spasticity is one of the most debilitating symptoms of MS. When the motor pathways in the spinal cord are demyelinated, the muscles lose their normal inhibitory control. The result is involuntary, sustained muscle contractions, a painful stiffness that makes movement difficult and exhausting. The legs are most commonly affected, making walking a significant challenge. Patients describe their legs feeling like lead, stiff, heavy, and uncooperative. When demyelination affects the cerebellum, the brain's coordination center, patients develop cerebellar ataxia. This manifests as an unsteady, wide-based gait, intention tremor, a tremor that worsens as the hand approaches a target, and dysmetria, the inability to judge distances accurately. Speech becomes slurred and scanning, called dysarthria. The eyes may show involuntary rhythmic movements called nystagmus. Multiple sclerosis also affects cognition and emotional well-being. Patients experience slowed information processing, impaired memory, and difficulty with attention and concentration, collectively described as cognitive fog. Depression affects up to 50% of MS patients, partly as a direct result of demyelination in the frontal and limbic systems, and partly as a psychological response to living with a chronic, unpredictable illness. The management of multiple sclerosis is divided into three main categories: disease-modifying therapies, relapse management, and symptom management. There is currently no cure for MS, but with the right combination of treatments, we can significantly reduce the frequency of relapses, slow disability progression, and maintain quality of life. Interferon beta is one of the cornerstone disease-modifying therapies for relapsing-remitting MS. It works by modulating the immune system, reducing the activation and proliferation of autoreactive T lymphocytes, decreasing their ability to cross the blood-brain barrier, and suppressing the inflammatory attack on myelin. It reduces the annual relapse rate by approximately 30% and slows the accumulation of disability. Natalizumab is a highly effective monoclonal antibody used for active relapsing-remitting MS. It works by binding to a protein called alpha-4 integrin on the surface of T lymphocytes. This blocks the T cells from attaching to and crossing the blood-brain barrier, preventing them from reaching the central nervous system and attacking myelin. Natalizumab reduces the annual relapse rate by approximately 68%. When a patient experiences an acute relapse, a sudden worsening of symptoms, high-dose intravenous methylprednisolone is given, typically 1 gram daily for 3 to 5 days. This powerful corticosteroid rapidly suppresses the acute inflammatory attack, reduces edema around the demyelinated lesions, and shortens the duration of the relapse. It does not prevent future relapses or change the long-term course of the disease. For spasticity, baclofen is the drug of choice. It is a GABA-B receptor agonist. It binds to GABA-B receptors on spinal cord motor neurons, reducing their excitability and decreasing the involuntary muscle contractions. Tizanidine, an alpha-2 adrenergic agonist, is an alternative that reduces muscle tone by inhibiting motor neuron activity. Gabapentin addresses both neuropathic pain and spasticity by stabilizing overactive nerve signals. For the debilitating fatigue of MS, 2 medications are commonly used. Amantadine increases dopamine and norepinephrine levels in the brain, reducing central fatigue. Modafinil promotes wakefulness by activating the brain's arousal centers, the hypothalamus and locus coeruleus, increasing dopamine, norepinephrine, and histamine activity. Both medications can significantly improve a patient's ability to function throughout the day. Multiple sclerosis is a complex, chronic autoimmune condition, but it is manageable. Understanding the pathology, recognizing the symptoms early, and applying the right combination of disease-modifying and symptomatic treatments can allow patients to live meaningful, active lives. The key is knowledge, vigilance, and a comprehensive, patient-centered approach to care.